Good afternoon and welcome. Thank you all for joining us today. I'm Samantha Watson, the Director of Member and Partner Services for the Florida Association of ACOs. We are excited for this opportunity to present to you the next installment of our webinar series, SDOH, a strategic approach to improving your organization's performance. Before we get started, I'd like to go over a few items so you know how to participate in today's webinar. You will see a user control panel on your computer desktop on the bottom of your screen. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select the arrow up on the mute button and choose switch to phone audio, and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions tab. You may send in your questions at any time during this presentation. We will collect these and address them during the Q&A session at the end of today's presentation, or you can raise your hand and we will unmute you to ask your question directly to the presenter. With that, I'm going to turn our presentation over to Halit.
Perfect. Thank you so much, Sam. And hi, everyone. Welcome. So with the flurry of activities this past year, especially around SDOH and health equity, it's become clear that checking the box is not enough, but being able to leverage SDOH insights and workflows is a huge opportunity to actually improve performance. Excuse me. My name is Halit Maydar-Alfi. I am founder and CEO of Spatially Health. Spatially Health was founded in 2019 on the principles of dignity and equity in healthcare. Today, Spatially Health is a cloud-based solutions platform that helps organizations identify and address health barriers due to adverse social determinants of health conditions inflicting their patients. By way of background, I'm a trained architect. I have a PhD in city and regional planning. And throughout my career, I've seen how location influences behavior, and that geomapping holds troves of latent data that can be mined to improve people's health and quality of life. Together with my co-founder and chief operating officer, Adi Siegel, and our team of data engineers, spatial data scientists, and analysts, we provide risk-bearing entities the products and tools they need to transition into that next level of value-based care. Today, I have two amazing guests that I'm super excited about from our partners at Illumid and Mom's Meals. We have Catherine McPherson, who's a Senior Vice President of Healthcare Strategy and Chief Nutrition Officer at Mom's Meals. And we have Sarah Wing, who is Director of Census Administration at Illumid. And we're here to share with you how our organizations are partnering to address social determinants of health. And we will walk you through an end-to-end social determinants of health strategy in action. So when it comes to social determinants of health, what are we actually solving for? Meaning, how are we going to go beyond this concept of social determinants of health and actually identify the health barriers for patients? I want to introduce you to Maria and Jennifer. They're both women, age 55, with diabetes and a medical history of hypertension and cardiovascular disease. So clinically, we can say that they are the same. They also happen to live in the same zip code, so there's no distinction. But there is a very big difference because Maria costs 42% more. This is because Maria lives in a food swamp leading to poor nutrition. And for a diabetic, a food swamp fares much worse than it does in a food desert. She also has limited access to transportation, therefore missing appointments, resulting in more frequent visits to the emergency room for non-urgent problems simply because it is closer and more convenient than her provider. We also see in many cases that people opt to go to the emergency room simply for a hot meal or even because they are lonely. So we never thought of emergency room as being a place to socialize, but apparently it does become so for some people. Maria is just one example of how non-clinical factors such as income, education, and location impact behaviors and decision-making at the individual level, leading to higher costs, poor outcomes, and health inequities. And as you know, this is what we call social determinants of health. So what do we know? So from the populations that we serve, we actually see that about 76% of the population has at least one social determinants of health risk. About 62% has two or more of these risks, and over a third has three or more social determinants of health risks. This amounts to close to about $300 billion in healthcare related costs. And one of the biggest misconceptions that we see working with social determinants of health, So from thinking about your patient population, do you know what your patient population is impacted by SDOH? And specifically, what are the health barriers that are impacting those patients' lives? And even more importantly, how are you planning on addressing those barriers and risks? So one of the biggest misconceptions that we see working with social determinants of health, it is not simply a data set that can be bought off the shelf. Rather, it is a complex and dynamic set of conditions that can change within short distances, let alone a zip code or a county. We have tools that have been introduced to us like the ADI that CMS is using to help us understand and evaluate which one of our population members live in higher ADI values, meaning higher vulnerabilities, and which ones are in low. And it often helps us plant a flag to know from the benchmark adjustment perspective how we're going to be compensated for taking care of more vulnerable patients. And also hopefully provides us the impetus to go after the more vulnerable patients, knowing that some of those costs will be covered. However, what we see in our experience is that sometimes higher ADI scores do not necessarily translate directly into health barriers, and conversely, lower ADI scores can equally translate into having health barriers, which are lost opportunities for providers to really understand their patient needs and address those needs. In addition, we have surveys which have been around for a long time. They're an unnecessary evil, apparently. They are an added burden, but it's really the best way to get the one-on-one information from a patient. The problem with surveys long-term is that they do tend to be inconsistent and incomplete, making further analysis and follow-ups somewhat challenging. But to have a robust solution that answers to individual patient needs, resources, and the overarching goal of driving health equity, SDOH needs to be modeled and understood at the individual level so that providers and provider teams can determine how best to serve their population. So at Spatially Health, we focus only on SDOH to identify and quantify the health barrier risks at the individual level, and then scale it out to any segment, cohort, any population, provider, market, geography, whatever the request is. Our proprietary models leverage location intelligence and spatial analytics that go beyond the zip codes and provide the granular insights at that hyperlocal level. And this allows us to do things a little bit differently, but with a lot more impactability. And some of the benefits that we see is, first and foremost, understanding and be able to prioritize patients through the SDOH and health barrier lens. So it's no longer just a matter of understanding or identifying who the highest cost patients are without the context of from a health barrier perspective, but also being able to layer on top of it the health barrier and identify those patients that go beyond the high cost and understand what their needs are to be more preemptive and proactive in taking care of them. In addition, workloads have become more heavier and harder with the added requests from CMS on health equity and better understanding social determinants of health. And we know that, again, surveys are time consuming, and if there's a way to shorten that, that is always welcomed on a provider team. We also know that social workers on average are about 1 to many, and we want to be able to make their time as more efficient and effective as possible. And ultimately, data is incomplete and often inconsistent that we see with the surveys or with the overall data that we have access to, whether it comes from EMR or other sources. Supporting providers is really important, especially in the work that we do. We want to be very clear on how it's going to impact them. Having a clear picture on the patients that they serve is tremendously beneficial so that they can also plan for it, and the care managers and social workers have the tools to do the individual outreach, including the health assessment surveys, if they choose to do so, any of the follow-ups or referrals that they see are beneficial to their patients. And ultimately improving the organizational performance, which is really what we're here for today. So being able to strategize at the population level is critical, but then being actionable at the individual patient level is ultimately what we're driving for. Being able to operate with much greater certainty in terms of budgeting, in terms of staffing, in terms of your overall workflows and operations is critical. And in addition, one of the things that's bringing us here today is having those right intervention service providers that we know would best serve our patient population and their needs, and be able to match the service levels that we have in the provider organizations with the services that we want to provide for our patients. One last point that I'll leave off is, from the population that we are servicing, we see that food insecurity and nutritional barriers are one of the greatest barriers that is impacting any population. We see about 46% of populations that have some sort of food and nutritional barrier. And that's really significant in terms of how do you want to approach such a big and heavy problem in any patient population. One of the services that we do provide, or the results of the work that we do, is giving the providers and our clients a targeted list of the patients that would be best served by particular services, in particular medically tailored meals. And this is why we're so happy to have Catherine and Mom's Meals join us and to help us walk us through their shared success at Mom's Meals and how they approach food as medicine.
Thanks so much, Halit. Can go to the next slide here. It's a pleasure to be here today and to kind of build on the great themes that you've established so far in the discussion today. We can move to the next one. Thanks for providing my intro. Again, very excited to be here. Before I dive into the topic at hand, I wanted to provide just a brief intro to the organization I'm representing. So Mom's Meals is a very mission-driven organization. Our mission is improving life through better nutrition at home. So on the next slide, we are a national provider of medically tailored meals. So we are one of those solutions providers that when those SDOH needs are identified, we're there to partner with healthcare entities like Illumed that we'll hear about today, in addressing the needs of patients and members. We've been at this for 25 years, and there is 2 decades of research behind the impact of medically tailored meals. We're the largest provider of medically tailored meals in the country today. We have a national footprint, so we deliver to every address in the U.S., every address in the state of Florida. And today we deliver more than 1 million meals a week. So we're really proud to do that. On the next slide. Our meals are refrigerated. So that's just something to know about us. People tend to have more room in the fridge versus the freezer, and they're very easy to heat and eat. We have the trays that you can see there and healthy sides that come along with that, like a fruit cup or cheese stick or orange or things like that. And the meals stay good in the refrigerator for 14 days. Right, on the next slide. And, we use the term medically tailored meals. Thanks for that. A lot of people will say, well, what does that mean exactly? It just means that we're providing a really healthy, delicious meal that meets the needs of clinical guidelines for the most common chronic conditions. And so we support 9 different menus today at Mom's Meals. Across all of our menus, we're going to have about 70 different choices. But when somebody has diabetes or heart disease or hypertension or CKD or ESRD, or if they're going through cancer treatment and they need extra protein and calories, we're going to have the right menu for that individual. On any given menu, we have between 25 and 35 choices. Our menus are also culturally specific. We have a kosher and halal menu as well. And within each of the menus, there are cuisines that represent a variety of cultures. Okay, on the next slide. So let's dive into the topic of food as medicine. So today, a real focus on nutrition has been missing from the healthcare system. I'm a registered dietitian, have worked clinically, worked in a hospital, and I have been that dietitian who's doing that post-surgery education on healthy eating, post MI, for example. And although it is a really great time to intervene with someone, there are so many additional barriers than just knowledge. And so we're talking about the social determinants of health today. So it's access to healthy food, financial access. It's also having the dexterity and ability to do meal prep. But we know that lack of good nutrition is the #1 driver of poor health outcomes in the U.S. And poor diets are the leading cause of death in those with lower incomes, living in rural areas, and in historically marginalized racial and ethnic groups. And, in looking at our population today, nutrition is critical. 3 in 4 adults are overweight or obese. 1 in 2 have diabetes or pre-diabetes, and it is costly. We know that for every dollar spent on food, the economy loses $1 in health harms. The next slide. And so quality nutrition is that important first line of defense in both preventing chronic diseases, but also helping to manage them when they exist today. And they do exist in a large amount. So 85% of older adults today have at least one chronic condition. And that's expensive. 85% of all of our healthcare spending in the US is related to the management of diet-related chronic diseases. Okay, on the next slide. And so, if we think about those costs, they're extensive. Nearly 50% of all U.S. deaths are from heart. Nearly 50% of all U.S. deaths are from heart disease, stroke, and type 2 diabetes. It's the leading cause of death in men and women in the U.S. And the death rate from cardiovascular disease for food insecure individuals is 75% higher. So here's where we're getting to that, disproportionate impact for people who have unmet social needs. All right, we can move to the next slide. In looking at that impact of access to food and mortality, it's not only for people with heart disease, it's not only for people with diabetes, it's across the board. So there's a 46% higher mortality rate for food insecure people than for those with a sufficient diet. So we really do need to find out who those people are and make sure those are addressed. And it really is critical. Halit was making a lot of just excellent points that, with any type of intervention, we want to know who's going to benefit most, who needs the solution the most, so that we get that return on investment. So in looking at, kind of the bigger picture of food as medicine in the US, public and private entities are taking notice and action. We're at the 1-year anniversary of the White House Conference on Hunger, Nutrition, and Health. And a lot has happened in that last year where we're advancing policy around food as medicine. Private organizations are committing grant money to nutrition programs, but also a growing number of health insurers and providers are incorporating food as medicine into the care that they provide to members and patients. Right, on the next slide. And so, what do we think of when we're looking at food as medicine solutions? So I talked about medically tailored meals, and there is, 2 decades of evidence on the clinical outcomes and cost savings of those medically tailored meals. Some other solutions are produce in pantry boxes or produce prescriptions. There's some promising evidence to date that when people have, the fresh fruits and vegetables delivered to their home, for example, you can have an impact. People will need to have, the space to do the meals prep and, the dexterity. And then pantry and food boxes, there's a little less evidence here, but, these are all different options that we are seeing some providers and some payers support around food as medicine. Okay, next slide. So Mom's Meals is very committed to establishing a strong evidence base for food as medicine. We've been part of, 5 published studies, 3 NIH funded studies. And so we always look for opportunities to partner with academic research institutions and payers who may want to, do a more rigorous analysis and publish that data so that others, can really benefit from that learning. But I won't go through each of these pilots here, but you can see kind of across chronic conditions, we've had just fantastic results around, including food as medicine protocols. And specifically in this research, they were all medically tailored meals and health outcomes and cost savings. And I do want to, on the next slide, kind of talk about one successful case study. And we, Mom's Meals at any given time has about a dozen case studies that are ongoing. And often these are with payers and providers. And, there isn't the clinical team or the research team to kind of take it through all the steps for publication. And so we like to share, case studies that are kind of that real world evidence as well. So this is a program focused on heart failure management with a payer in California, and everyone who enrolled is a dually eligible member. And the program was 6 months in length. So this pilot program was 93 individuals living in a rural area just east of Los Angeles. Okay, next slide. And the results were fantastic. So people got 6 months of medically tailored meals, produce and pantry boxes were included, calls with a dietitian. Mom's Meals also did provide the produce pantry and dietitian calls. And the outcomes after 6 months was a 50% reduction in hospitalizations, a 50% reduction in trips to the ED, and people had good clinical outcomes as well. They lost weight. So the average weight loss per person in the pilot was 6 pounds. So that nice, steady, slow, sustainable weight loss was wonderful to see with that dietary change. All right, on the next slide. This translated into a lot of cost savings. So a 25% cost of care savings for people who were in the program, and also an improvement in medication adherence. So addressing one need, really led to, the ability for patients to focus on other aspects of their self-care as well. All right, and lastly, I just want to leave you with a story. And so this is Lavinia. She participated in the pilot program. She has heart failure, and she found that she couldn't breathe one day, and so she went to the emergency department. When she got to the hospital, her oxygen was just at 2%, and she thought she wasn't going to make it. When she got home from the hospital, she was recovering, but she started to have panic attacks and anxiety about getting that feeling about not being able to breathe again. And she said, that kind of put her over the edge, and she would end up going to the hospital just about every other day. And then, she got this program. So she got 6 months of prepared meals delivered to her home. She said the food was fantastic, and all she had to do was microwave them. And the meals and the calls during the program helped to bring her anxiety down and really to help her be calm. And so, she said she was grateful because she felt that people really cared. She was following a low salt, low sodium diet for the first time. Her doctor really saw her progression, and she learned to control her weight. She went from 280 pounds down to 236 during the pilot program. And, her symptoms were non-existent, and her condition was stable. And she really said the program helped her to be a better person and saved her life. So with that, I'm going to wrap up on this last slide. Nutrition, really does add value to your program. It drives engagement with your patients, and it's low cost. If we really provided good food to people, they wouldn't need so much downstream healthcare. So it really is designed to improve clinical outcomes, be preventative, address the social determinants of health, drive your quality measures, your have MIPS that you need to meet, for example, reducing admissions and readmissions, lowers the total cost of care, really does engage patients in other aspects of their self-care as well. And meals programs really are, easy to implement. We've been doing this for 25 years. So with that, I'd love to turn it over to Sarah to talk about what they're doing at Illumed.
Thank you, Catherine, so much. And thank you, Halit, too, for getting us started today. Good afternoon, everybody, and welcome to our webinar leading into the conference next week. So I am here on behalf of Illumed. We are an ACO. We are in Florida, and we're also all over, and we're continuing to expand to work with patients all over. We're in 10 states right now, and we're continuing to grow. So we're very excited to keep the trend going, just like Catherine said several times, of identifying food as medicine. We really, really recognize that that is going to be a huge impact on all of our patients. Next slide for me, Halit. Thank you. So a quick introduction to Illumed. We formed in 2018, so very similar to Halit with Spatially. We are relatively new. We are a baby in the world compared to Mom's Meals, who has been around for a couple of decades. We were one of the original, what was formerly referred to as a direct contracting entity. We started with a very, very small group of beneficiaries. We were in only a handful of states. We've continued to expand, and then we transitioned into that ACO REACH program. And we now have over 54,000 beneficiaries to grow even more next year, and we're in 10 states right now. So there has been a lot of growth in such a small amount of time. We're still seeing that happen. We're still seeing the impact that we're recognizing in all of our markets, and how everything can change so very quickly with policy, with programs, with expectations, everything like that. Next slide for me, Halit. Okay. So one of the first questions that we have is, what barriers do we have as an ACO REACH? What are we up against? What can we recognize for our providers as a barrier? What can we recognize that our patients are reaching as barriers? And how do we resolve that? How do we address that? So some of the biggest ones, some of the biggest barriers that we have been able to recognize, the geographical location. So as Halit mentioned, we have patients that share zip codes, and that can very much change for those patients. Even if they share a zip code, their experience might be completely different. Their access to care, their access to transportation, their access to food, all of those things can vary greatly just simply based on their geographical location. What is their access to community resources? So there's kind of two parts to this access to community resources. Sometimes it's just knowing that they're there. We have some patients that are in communities that do have extensive resources available. They just don't know that they exist. There's no education around it. There's no way to connect to it until you ask for it, or until somebody recognizes that you need it and they can get you connected to it. Other communities we have minimal community resources. They, despite knowing that there is a need for it, it's very hard sometimes to keep those community resources up and running, because who is accessing them? How are we funding them? What does that look like? So what is the access to community resources? How are we reaching that barrier? How are we identifying it? How are we solving for it? And one of the biggest ones, the one that is the hardest to solve for, is the engagement in services. So how are we recognizing that a patient, a client, a beneficiary needs services? And how are we getting them involved in it? How are we communicating that need? How are we having those conversations so that we can get them involved in their healthcare, involved in being healthy, staying home? Obviously, like, our biggest goal as an ACO REACH and for all of our providers is letting our patients live healthy, long lives at home or wherever home may be, whatever that comfortable location would be. So engagement in services can be very beneficial for our patients. It can also be a huge barrier. If they don't know who we are, if they aren't sure how we're helping them, if they're not getting anything out of it, right? How do you keep talking to somebody if you don't know what they're going to help you with, if you can't see the results from it? And how are we measuring the outcomes? So how are we recognizing that we are having an impact on these patients, on these beneficiaries? What is the social work team at Illumina doing? What kind of conversations are they having with these patients? How are they communicating what is available to them? How are they obtaining the information during an assessment, during a conversation on what the gaps are, what the needs are? And working side by side with our nurse case management team and our providers to be able to get them participating and get them engaged. So how do we measure that? One of the biggest things that we see is that we can measure it from the provider level. So the primary care physicians, what kind of feedback are they getting during their appointments with the patients? Are we seeing that the patients are attending more appointments because they feel like their provider is more involved in their care? They've connected them with a resource or somebody who can see them and talk to them in between those visits. We know some patients are willing to be seen more frequently. Some of them only want to go once a year. So if you're only going to the doctor once a year or once a quarter, there's a lot of time in between those appointments. How are we communicating with those patients in between those appointments? Similar to what Catherine had mentioned with her testimonial patient, the patient going in and out of the ER frequently. As soon as she had somebody that she knew she was going to be talking to on a regular basis, those ER visits went down drastically. Some patients are worried about bothering their physician. They don't want to interject into their daily routine because they don't have an appointment. They don't want to have to leave a message. They don't want to cause any frustration to their provider. And also the feedback that we get directly from our beneficiaries. We are measuring how they like the meals that they're getting. That's a huge one. Is it helpful? What is it doing for you? How is it impacting you? Is it relieving stress? Are you eating more regularly? Is it changing any of your health outcomes? Are you noticing differences in your weight or your sugars, or even just your edema, how much you're carrying around with you? So there's a lot of different ways that we're trying to look at measuring that success and what that looks like. Next slide for me, Halit. Perfect. So the biggest thing that we have recognized this year, as we have focused more on SDOH, and as our social work team has come on board and been growing, is the need to go back to the basics. What is really impacting health outcomes and patients' well-being? So I did include on here the hierarchy of needs, because sometimes we get caught up in what we actually need to start with our patients, right? We're trying to figure out how to manage their congestive heart failure. We're giving them all of this education. We're trying to support them. And then we realize that they're really worried about where they're living or how they're getting their food, or even just where they're going to sleep each night. And so how can we educate a patient on managing and monitoring their weight when they're worried about some of those physiological needs? They don't know some of those basics. And so they're not worried about what their weight is. They're not worried about what their blood sugars are. And they're okay going to McDonald's because at least they know that they've eaten today. So how do we prioritize and recognize that we need to focus on the basics, that we need to make it less complicated when we're talking to our patients? We need to assess for where the gaps start. And how does that lead us to having a positive impact, not just on their health outcomes, but generally on their well-being? And a lot of times we have patients that we've recognized that have an SDOH disparity. They have some sort of health inequity related to financial insecurity, housing insecurity, food insecurity, even safety. They just don't feel totally safe at home or wherever they're living. And they find that that's not relevant to share with their provider. So their provider is telling them that they need to lose weight, or they need to eat healthier, or they need to do X, Y, and Z. And they don't think it's relevant to tell them that the reason why they're eating high fat foods, high sodium foods, high anything like that is because that's all they can afford. They don't feel either comfortable sharing that. They don't think it's relevant, or it's something related to embarrassment. They don't want to share that. They don't want to have anybody looking down on them or worried about them. So how do we guide our physicians as well, our primary care providers that we work with, to ask those questions, to recognize that it might not just be a health issue, but it could be something more? And it just takes us back to this place of getting a little less complicated with what we're talking to our patients about, and how are we communicating with them. Next slide for me, Helene. So before I dive into questions, because I have a couple more points, I just didn't have any additional slides. I did want to share one of the ways that we have been able to use spatially Mom's Meals, and I really want to reference back to what Halit had mentioned as well with the CMS use of the ADI, because that has really been kind of where we started with this year, was using the ADI, because we are brand new to working with spatially and to having them on board with us. So one of the things that we recognize at Illumid is, how do we ask the questions? How do we get the information? How do we capture this? So we do have a health equity assessment that we do with all of our patients. It can be done over the phone with them by our care team. It can be done in the provider's office when they're in there for a visit. It can even be done on paper via mail when they get their welcome letter, when they get introduced to Illumid, when they come on board with us. Once they do that assessment, if there is anything that stands out, we are able to contact them directly. Our social work team reaches out and has a conversation with them. They recognize that these are the responses that they gave to us. How can we help you? How can we expand on that very simple question that's a yes or a no on a piece of paper? How can we find out more in terms of what that means? And if a patient isn't doing that, they haven't gone into their provider, they didn't do the piece of paper, but we want to call them on the phone. We want to just ask them, we haven't seen them in, and something stands out. Something is flagging them in our system as we need to connect with this patient. And prior to coming on board with Spatially and seeing how this partnership is going to work with our teams to recognize those patients, we have really been using the ADI, so the Area of Deprivation Index. It is, as best as it can be, a way for us to recognize that a patient might be in a space that might put them more at risk. So we use the ADI, or we had been using the ADI, as a way to reach out to patients that hadn't been reached out to before, to recognize that this might be a patient that hasn't seen their provider or didn't want to do the form, didn't do it while they were in there, or didn't do it over the phone with us for whatever reason. They might not have had a number of emergency room or hospital visits that would have put them on our radar before, but it doesn't mean that they don't have chronic conditions. Like Halit had mentioned, there's quite a few patients that have 1, 2, or more chronic conditions. We can't say that this population doesn't. So one of the situations that we had, one of our social workers, from her list of patients who was higher at risk on the ADI scale, she contacted this patient just to reach out to have a conversation, to do a quick introduction to Illumid, because she didn't have any prior hospitalization. She hadn't been in contact with our case management team previously, so she was new to our program. And during her conversation, during her opportunity to build rapport with the patient, she found that the patient often ran out of food by the end of the month. That it's not for lack of trying, but she no longer drove. She didn't have any transportation, and she really relied on her son to get her to the grocery store. But financially, she could get what she could get. And so she was finding that towards the end of the month, she was having to kind of scrape by. She was having to make things last and extend them. And so what Amy, our social worker, did is she was able to just talk to the patient about the resource that we had with Mom's Meals as something that she could utilize for that program, to be able to say, let's take some of that burden off. Let's see what this does for you. On a short-term scale, let's see how this will impact your perspective on what you're able to do. And the patient really was in the program. She worked with Mom's Meals, getting those food deliveries for those medically tailored meals for about 3 months. And the patient said, it has been so nice. I've been able to save up a little bit. I don't feel as stretched thin, and I have plenty of food in my refrigerator. I'm able to eat every day, and sometimes I have too much food. Sometimes I'm inviting my son over so that we can have a meal together. So not only has it impacted on a financial level, but on so many other levels. Her well-being is better off. She's getting meals that tailor to some of the chronic conditions that she has. Even though she wasn't a patient that was going to the hospital or the emergency room, she now is more inclined to go see her provider more regularly, because she knows that her provider was the one that initiated this relationship to have a case management team and to have an ACO REACH partnership from that perspective. So there's a lot of different ways at Illumid that we are seeing that being able to not only identify our patients, but to give them the resources that they need, to connect them with the services that are going to help them, kind of gives them this full experience to be able to have a positive impact on what they're doing. So with that being said, now I will switch it over to questions, and Halit, I will pass it back over to you to take that lead from us.
Thank you. I appreciate that, Sarah. And Catherine, Sarah, I really appreciate the time, in going into your experiences and how the solutions that you have are addressing the health barriers and finding those precise referrals to the patients. One of the things that we most appreciate about Illumid is your sheer commitment, and for Mom's Meals, the sheer commitment to addressing social determinants of health and doing it at the individual level. I think it goes without saying that especially for Illumid, the commitment to medically tailored meals, which is a high value service that you're providing to some of your patients, and just the ability to provide exactly what those patients want from Mom's Meals is pretty impressive. I want to go back to try to put together, all the points that were discussed here, because I think a lot of information was passed along. When we're looking at a situation for any one of our clients, and we have the full breakdown of the health barriers that we see across their patient population. Now it's a matter of understanding, okay, now what? What do I do, understanding that I have certain patients that have food health risks and health barriers. Some have transportation barriers, some have mental health. There's a bunch of other barriers that any one of these populations is living with. And for the nutritional part and what we see happening in food insecurity and nutrition, if almost half of the population is suffering from that risk, that's a big population to address. And it obviously cannot be done all at once or even consistently across all the patients. So for our clients and for our providers to know, okay, if I have these amount of patients, the entire population or half of the population that needs these particular services, how do I prioritize them? How to actually go and address and start understanding which one of these patients do we want to address first that are most critical, either from a chronic condition perspective, but also from an SDOH perspective. Again, to try to be more proactive and be able to get these patients the services and the attention that they need so that they are better engaged, right? And they can have the better outcomes or achieve the outcomes, the health that they can achieve. So to start off with being able to identify and prioritize from the client's perspective, are you working with a specific budget? Are you working for a specific population? Is this a chronic condition that you're going after for the REACH ACOs? Is this from a health equity perspective? There's something there that you wanted to attach. All this becomes part of the broader strategy and really figuring out how do we fold in the health barriers that our patients are suffering with the solutions out there so that we can still reduce the workload, we can get the outcomes that we want to, and we can ultimately reduce the cost. If medicine is going towards precision medicine, we want to also go to precision referrals, and that's what we're here about. So I appreciate all your input, Catherine and Sarah, fantastic presentations. Sam, I think we're ready for some questions.
Okay. What data is needed used to do the health barrier analysis?
I think that's a question for Spatially Health. So the reality is what data that we use a lot of different data inputs. In all honesty, we use probably the same data that most everybody uses. The thing is what we do with that data, which makes us unique, and the model that we provide that really allows us to come out with the insights that allows to understand at the individual level what is actually happening from a health barrier perspective. So the data input is very similar as everyone else. It's what we do with it, which adds a lot of value afterwards.
Okay, thank you. For Mom's Meals and Illumid, how long is a patient typically enrolled in a MTM program?
I can take that from I was going to say from an Illumid perspective. So we, in our partnership with Mom's Meals, we actually, we have 3 different programs that we've designated with them that we during our initiation, we put in place. So we have a post-discharge program that our patients can engage in. It's getting 1 week of meals for that post-discharge. They've come straight out of the hospital, gets them back on their feet. Maybe they're still recovering, they're transitioning, they just got out of the hospital, they haven't been to the grocery store, whatever that may be. We have that initial post-discharge that they can do, which is just a single week. And then we have 2 other programs. We have a chronic condition program, and we have an SDOH program, depending on what we're identifying as the need or the gap. Both of those programs do have a 3-month time span on them, but we can renew them if we need to. Typically during that 3 months, our social worker is looking to connect them with a long-term solution, with a community resource. They're trying to identify the impact that resource with Mom's Meals, that connection to Mom's Meals is having on them, so that we can see how that plays out at that 3 months. So right now, the longest that we have is a 3-month, but it can be extended. It is something that we can continue for our patients if we need to, as the social workers continue their monitoring and their outreach with those patients.
That's great. I would add just maybe 2, just to build on what Sarah said with 2 points. One, in kind of that 1 week and 12-week programs, those would be 2 meals a day. So, the 1 week program is 14 meals, and that would be 14 meals per week for the longer programs. Yeah, and I would say that also those are pretty typical. What like a post-discharge program does tend to be that shorter, I would say the longest post-discharge program we've seen is 4 weeks, but it's usually 1 to 4 weeks after discharge to help with that rest and recovery, to make sure that, someone, if they're not allowed to drive, they're not supposed to be, on their feet for long periods of time. They're not supposed to carry a heavy grocery bag, or, getting onto a bus might be a challenge, for example. So, that can really help prevent readmissions. We have data that's published and in case studies shows that we can prevent 25 to 50% of readmissions with the post-discharge meals program. And then that chronic condition program, we do recommend that 12 weeks, as the amount of, as far as getting your A1C tested again, you're really not going to do that before the 12 weeks. So helping to stabilize that chronic condition, if that's, hypertension, or if that's diabetes or heart failure, you're really starting to see some early clinical outcomes, but it's also enough time to work with a team of folks to have a longer term game plan, whether those are folks from the provider like at Illumed, or we have dietitians at Mom's Meals. We can help create a program for sustainability long term, definitely tapping into community resources, for example.
Thank you. Our next question is for Illumed. What happens once they are no longer able to receive meals? What does the long-term plan look like?
Absolutely. So one of the biggest things that we promote within Illumed is that food is medicine. So we are never going to leave a patient hungry. We are never going to remove a resource unless we do have an option for them in place. So a lot of times it is identifying what the real gap is. Is it a financial issue? Is it an access issue? Is it an education issue of just getting them on board with what foods they do need to eat? That's really going to guide us on what those long-term solutions might be. So is it connecting them to a community resource, like a Meals on Wheels, that's going to be right there with them, that they qualify for because they're homebound? Is it connecting them with financial resources in the community that can help with some of their bills, or even medications? If they're finding that they're having to choose between food or medications, and that's why they're struggling with their food insecurity. So a lot of times the biggest answer to that is what is the gap? What is the need? What's causing the food insecurity? In terms of what the long-term solution is. Are we having to solve for financial issue, a housing issue, something like that, that's not just simply a food insecurity, that they just don't have access to it? Do they not have transportation to get to the grocery store? All of those things. So there's a lot of aspects to that in terms of how we solve for that and how we find a long-term solution. And that's what our social workers are doing every day. And they're building relationships with community resources as well to expand on what is available, what do we know about, and how can we let our patients know about it.
Thank you, Sarah. I do have another question for Mom's Meals. What is the average cost of Mom's Meals?
Sure, happy to take that. So we also have, we have direct contracts with healthcare organizations like Illumed. And we also just have Mom's Meals available at momsmeals.com for anyone who just wants to buy meals as a caregiver, for themselves, for whatever reason. And the pricing is out on our website. It's $7.99 per meal or $8.99 for renal, pureed, or gluten-free meals, which take a little more. Work in meal preparation. We do cook all of our own food. And then, those are a little bit higher price point, $8.99 per meal. And then when you do buy online, there is a $14.95 shipping cost per delivery. But when we direct contract, pricing may vary based on geography and then the protocol, like how many meals per cooler, because shipping costs will be baked in, to that per meal pricing. So, but that just gives you a good estimate, out there at that $7.99, $8.99 price point, and then shipping.
We have one last question today, and it's for Illumin. How are you determining who would be best suited to receive medically tailored meals?
Absolutely. So it really is going to be that assessment that our social workers are doing. So we have social workers on our team that works with the patients in the hospital that can identify is there a need for it when they're getting discharged. We also have our social workers that are working with patients day to day. So we might get a direct referral from a primary care provider that says, hey, I just had the patient in my office today. They need something. We need them. And they might recognize it as their A1C has just been rising and rising and rising. We need to get them more educated on a diabetic friendly diet. And so we might start with connecting them to Mom's Meals so we can say, this is what diabetic friendly meal options look like. This is how you can eat food. This is how you can make something tasty that still falls within that diet plan. We also are assessing if it is an insecurity that we're recognizing, that they don't have access to food, they can't get connected to that. So it's the conversations that our social workers or nurse case managers or even our providers are having with those patients. What are we recognizing as the need? All of our patients would be eligible. It's just doing that assessment to see if it's appropriate. Would they benefit from it? Do they need it? Is it going to be helpful? And that's how we kind of see that impact that we can have on those patients.
Thank you, Sarah. And thank you to our panelists for joining us today to present this information to us. And thank you everyone for joining in on today's webinar. As you see on the last slide here, Spatially Health and Illumin will be here with us at the Fall SACOS Conference. It's our 10th anniversary, so we hope you all will be joining us for all of our great panel discussions that we have, along with our social determinants panel that's taking place on Thursday. We will have a big celebration too Thursday evening for our 10th anniversary party. So make sure you register. Registration is still open up until the day of the conference. We will also be sending out an email with this contact information if you have any follow-up questions, along with a link to the webinar recording. We ask that you share this link with anyone you think will be interested in learning more about SDOH and what all the companies on our webinar are doing. We hope you all have a great day and take care. Thanks.
Thanks, Sam. Bye, everyone.
Thank you, everybody.